How's it going, guys? Past level question, metabolic step 1, step 2, 50-year-old woman, low serum calcium 8.2 should be 8.4 to 10.2, phosphate high 5 should be 3 to 4.5, bicarbonate low 21 should be 22 to 28. So we have down arrow calcium, up arrow phosphate, down arrow bicarb. This is very easy. I didn't give you a vignette for a reason, okay? Because you got to know diagnoses. You got to be able to diagnose based on labs. That's what I'm trying to teach you with questions like this. This is renal failure. Okay, so when calcium is low and phosphate's high, never mind the bicarb for a moment. You say that's secondary hyperparathyroidism, which is basically synonymous with renal failure on USMLE. Okay, so when we have primary hyperparathyroidism, primary being parathyroid adenoma, diffuse foregland hyperplasia, we'd have the opposite. We'd have high calcium, low phosphate. But in renal failure, we've got low calcium, high phosphate. Could spend 40 minutes talking about the mechanisms. That's fine. But when bicarb's low especially, you know it's renal failure. It clinches it because isn't renal failure uremia, which is the U in mud piles? So it's a high anion metabolic acidosis with secondary hyperparathyroidism here. So I'll talk more about the renal failure and the mechanisms a little bit as we move through. Let's just hop through. What's most likely to be seen? Choice A, adenomatous proliferation, wrong fucking answer. Flowery, verbose answer choice refers to parathyroid adenoma, and you know it's not right because, as I just briefly mentioned, if this is primary hyperparathyroidism, then we'd have high calcium, low phosphate. Parathyroid hormone normally going to cause calcium reabsorption in the late DCT of the kidney. It will cause calcium release from bone via elaborate rank-L-rank interaction. It'll activate 1-alpha-hydroxylase in the PCT of the kidney, increasing 1,25-D3 synthesis, which goes to the small bowel, increases calcium absorption. So calcium would be high, phosphate low. The PTH will also decrease phosphate reabsorption in the PCT. Wrong fucking answer. Choice B, defect in MEN1 gene, wrong fucking answer. MEN1 classically pituitary, pancreas, parathyroid. And I can tell you that for the MEN syndromes, MEN1 as well as RET gene for MEN2 syndromes, they don't have to give you everything in the constellation. They can just give you, let's say, medullary thyroid cancer, and the answer is RET gene. And you say, well, there's nothing about pheochromocytoma. There's nothing about parathyroid adenoma for MEN2A or marfanoid body habitus for MEN2B. It doesn't fucking matter. Okay, so this could refer to, if we're talking about a parathyroid adenoma, it could be MEN1 or it could be RET. Okay, RET for 2A. So we just talked about for choice A, I mean, it's the same thing. You'd have primary hyperparathyroidism, high calcium, low phosphate. Wrong fucking answer. Choice C, diminution in intestinal calcium absorption. Correct answer. Diminution just means reduction. So in renal failure, PTH can't do its job at the kidney. Therefore, it can't activate 1-alpha-hydroxylase the way it's supposed to. So it can't synthesize 1,25-D3 the way it's supposed to. And we said 1,25-D3 normally goes to the small bowel, increases calcium absorption. So we'd have decreased serum calcium. That decreased serum calcium, decreased negative feedback of the calcium sensing receptors of the parathyroid glands. PTH goes up to compensate. That's why we call it secondary hyperparathyroidism, because the high parathyroid hormone is not due to the parathyroid gland being dysfunctional itself. It's because of an external cause, i.e. the kidneys. So some of you are going to get confused. I'm going to make a very important point here. You say if 125-D3 is low, why isn't phosphate also low? Because D3 will cause both calcium and phosphate absorption in the small bowel normally. So rickets, osteomalacia, let's say, unrelated to renal failure, correct. You'd have a down arrow for both calcium and a down arrow for phosphate. But as I've talked about in my PDFs and in my other clips, if renal failure is the etiology for the reduction in vitamin D, the renal failure wins over the mere decrease in vitamin D. And phosphate's always high in renal failure because the kidney can't get rid of it. Okay, so it's very important you know that distinction there between vitamin D deficiency due to renal failure and vitamin D deficiency unrelated, dietary deficiency, alcoholism, etc. So they can give you a vignette of renal failure, ask you why there's hypocalcemia, and the answer on the USMLE will just be decreased intestinal absorption. Not hard. Okay, let's just whip through the final answer choice here. Renal tubular acidosis, wrong fucking answer. It's a lengthy discussion. Okay, it's not going to cause renal failure in and of itself, classically, which we wouldn't expect changes in calcium per se. It's not the best answer choice here. C is a better answer choice. I've made clips on this. The way RTA is going to present, it's a normal anion gap metabolic acidosis. So they'll give you a 15-line paragraph. You'll calculate the anion gap as normal. So you take chloride and bicarb, add them together, take that number, subtract from sodium. If it's 8 to 12, it's normal. 13 or greater is high. And they'll list answers that are all mud piles. You'll calculate as 11. They'll list answers like lactic acidosis, DKA, salicylate poisoning. And you can eliminate them because you say, well, anion gap's not high. And then you're left with Crohn's disease or RTA. And you say, well, the vignette's clearly not Crohn. I guess this is RTA. That's what they do. It's a diagnosis of exclusion. Wrong fucking answer. Choice Z, decreased total body potassium, wrong fucking answer, refers to diabetic ketoacidosis. So in renal failure, in this patient, you're going to have not only hyperkalemia, but the kidney just can't get rid of the potassium. Okay, that's why you have high potassium. So it's not going to be low in the body, it'll be high. In DKA, you have hyperkalemia, but the kidney can do its job effectively. So it's getting rid of all that high serum potassium. So you have low total body potassium in DKA despite hyperkalemia. Choice C, wrong fucking answer. You know the deal. I'm going to make more content like my stuff. Appreciate your time. That's it.